Perform a thorough assessment, including history of pain, last meal, gastrointestinal symptoms, and reproductive history in females. Monitor vital signs and consider life-threatening causes like gastrointestinal bleed or ruptured aneurysm. Avoid oral intake and transport to an appropriate facility. Pain control may be provided per local protocol, such as fentanyl or morphine. Administer aspirin 324 milligrams unless contraindicated. Obtain a 12-lead ECG within 10 minutes. If chest pain persists and blood pressure allows, give nitroglycerin 0.4 milligrams sublingually every 5 minutes, up to 3 doses. Avoid nitro if systolic blood pressure is under 90 millimeters of mercury, or if recent erectile dysfunction medications like sildenafil were used. Notify the destination facility early if STEMI is suspected. Assess for common causes: hypoglycemia, stroke, seizure, overdose, trauma, and infection. Check blood glucose and treat if low with oral glucose if awake, dextrose or glucagon if unresponsive. Consider naloxone Narcan if opioid overdose is suspected. Ensure airway protection and oxygenation. Epinephrine 0.3 milligrams intramuscularly for adults or 0.01 milligrams per kilogram. Intramuscularly for pediatrics should be given early. Administer diphenhydramine and albuterol for wheezing, and consider steroids if available. If the patient deteriorates or has airway involvement, prepare for advanced airway intervention. Consider an epinephrine infusion in severe or refractory cases. Ensure scene safety first. Attempt de-escalation before restraint. If necessary, use physical or chemical restraints per protocol examples. Midazolam, ketamine. Always monitor airway and vital signs post-sedation. Document behavior and response. Assess for symptoms like hypotension, altered mentation, or chest pain. If unstable, administer atropine 0.5 milligrams IV, may repeat every 3 to 5 minutes to a maximum of 3 milligrams. Consider pacing or dopamine epinephrine drip if atropine is ineffective. Transcutaneous pacing may be initiated en route. Remove clothing and begin active cooling with ice packs and misting. Initiate IV fluids. Monitor for seizures or arrhythmias. Rapid transport is critical. Gentle handling is essential. Remove wet clothing and begin passive or active rewarming, depending on severity. Monitor for bradycardia and arrhythmias. Withhold medications and defibrillation in severe hypothermia less than 30 degrees Celsius until rewarmed, unless VT or VF persists. Protect airway. Do not restrain movement. If the seizure lasts more than 5 minutes or recurs, administer midazolam IM, IV, or IN lorazepam or diazepam. Check glucose and treat accordingly. Postictal monitoring is essential. Time of symptom onset is critical. Use a stroke scale, for example, Cincinnati or Los Angeles. Obtain blood glucose early. Early notification of a stroke center improves outcomes. Keep the head of the bed elevated and avoid hypotension. Consider cardiac causes, especially arrhythmias. Obtain ECG and check glucose. Treat the underlying cause: fluids for dehydration, glucose for hypoglycemia, and so on. Administer ondansetron, also known as Zofran, orally or IV if available. Monitor for dehydration or electrolyte imbalance. Consider secondary causes such as pregnancy, GI obstruction, MI, or infection. Position the patient for comfort and support ventilation. Administer oxygen and escalate to CPAP or BVM if needed. Consider potential causes like asthma, COPD, CHF, pneumonia, anaphylaxis, and so forth. Administer albuterol and ipratropium duo-neb. Consider corticosteroids, either oral or IV. If the situation is severe, add epinephrine IM or magnesium sulfate IV. Be prepared for respiratory fatigue and the possibility of intubation. Position the patient upright, administer oxygen, and initiate CPAP if it is available and tolerated. Nitroglycerin may be used if the systolic blood pressure is above 100. Consider IV diuretics like furosemide according to protocol. If glucose is under 60 and the patient is alert, give oral glucose. If the patient is unconscious or unable to protect their airway, administer dextrose IV or glucagon IM. Monitor for recurrence. Avoid insulin in the field. Administer intravenous fluids if signs of dehydration are present. Monitor for vomiting, dehydration, or altered mental status. Ensure airway and ventilation. Administer naloxone, also known as Narcan, 0.4 to 2 milligrams intravenously, intranasally, or intramuscularly. Repeat every 2 to 3 minutes as needed, up to 10 milligrams. Monitor for rebound sedation. Contact poison control or medical control early. Consider activated charcoal only if the airway is protected and within 1 hour of ingestion. Treat specific agents with appropriate antidotes, for example, naloxone, atropine, or calcium. Prioritize oxygenation and ventilation. Consider the possibility of aspiration pneumonia. Treat hypothermia if present.